diagnosis, and we might then go into the case that might introduce some themes that could bring out some more questions. Katie, why don't you tell us about the very beginning?
I had fairly young children at the time, so I was probably putting being tired down to just having children that didn't sleep very well. But I just felt like something was wrong, so I kept badgering my GP, and she sent me for an ultrasound of my gallbladder, and I said to her, I think I have Crohn's or I'm celiac, there's something not right. And people have been telling me I was losing weight and I wasn't trying, so that sort of hit alarm bells, because that was just an obvious sign. I actually remember saying to someone probably 5 or 6 weeks before I was diagnosed that, oh, there must be something eating at me from the inside, because I'm not trying to lose weight, but I am. And I had an ultrasound, and they found some spots on my liver. And so I had a CT that day, and it was New Year's Eve, and they said to me, look, we don't normally tell patients, there's the head radiographer at the place, and he said, but there's a mass on your pancreas, which isn't an easy time, New Year's Eve, to sort of, when everyone's closing down to celebrate, to sort of find out that you've got something on your pancreas and in your liver. But when I did see my GP, as soon as they opened after New Year, when she knew I had a mass on my pancreas, she instantly thought, right, I'll send you to a great surgeon, Jazz Samra, who I guess started the ball rolling for me in terms of putting me under the care of amazing doctors that actually part of the multidisciplinary team. So I do see myself as being lucky that I was straight away put into the hands of people that have an interest in the disease, because no one can really say how long I'd had the disease for, and that started my journey, which is 7.5 years onwards so far, and I don't think there's many treatments I haven't had over the time. And yeah, so that's sort of how I was diagnosed. But I do a lot of volunteer work through the Unicorn Foundation and also the Cancer Council of New South Wales. And I do come across a lot of patients that I know it's taken a long time for a lot of them to actually get help from people that actually understand and know what they're doing. And some of those people, when they come to a support group or they talk to the nurse on the phone through the Unicorn Foundation, they often get steered in the right direction, or just by asking questions, they start to actually, realise they have to be their own advocate. And I guess sometimes the support groups in the Unicorn Foundation do perhaps push them towards asking the right questions, because everybody deserves equal care, and it's not so easy in a lot of the regional and rural areas. So that's why I like to try and help out as much as I can, so everyone can have equal access to care.
We might use this as an opportunity to present your case, Katie, with the pictures. It's only a snapshot, mind you, because there's a lot more than this here, but I'll leave it for Paul for the moment.
Trust me, if we were going to present Katie's whole story, we'd be here at this time tomorrow night. Katie is a platinum frequent flyer in our department. And we are always glad to see you. And look, I must say, I think to have your scan shown in an audience, thank you very much for doing it. But it will show a journey. Katie's journey is about as complex as you're going to see, but I think it'll give you an opportunity perhaps to touch on some of those ideas. Just for the first few minutes, I'm going to put my nuclear medicine hat on and just tell you a little bit about some of these scans. I know quite a few of you will have had them, but this is a PET scanner, a PET CT scanner. These things cost about $3 million, and we have most of the big hospitals have them. We have one here in the public hospital and one over in the private. So on the scans I'm going to show you, there are some things that are meant to be there and some things that aren't. So this is a gallium dotatate scan. So that's the liver, that's the spleen, that's the kidneys, the bladder. That's the pituitary gland, and you can make out a thyroid scan. So there are things, what we're looking at is somatostatin receptors. There are normal organs in the body that have these. So when you see the scans, don't worry if you're seeing livers and spleens, they're meant to be there. Some of you may have had this, which is an FDG, fluorodeoxyglucose is what FDG is, so it's an FDG PET scan. This is actually the most common PET scan that we do for a lot of different tumour types. The brain lights up on one of these, that's the heart, and you can see again liver, spleen, that's the bladder. So that's what we expect to see. And in case you're thinking, gee, they spent $3 million and all they get is black and white pictures, we do have a CT and we do get colour images and we look at it in different planes. So we look very important when we're reporting them, but there is a lot of information there. All right, so Katie's journey. So we didn't start doing lutate therapy here until 2013, 2014. So before that, she actually had some treatment at St George. So I'm going to just skip very briefly through that. You tell me if I've got any of it wrong. And excuse the big, there are a few big words up there, but as Katie said, she originally had a lesion in her pancreas with some spots in the liver. The pathology on that was a G3. Now, Mustafa mentioned this, that there are different grades, a G1, G2, G3. G1 is a less aggressive, G3 is a very aggressive tumour. So she actually had quite an aggressive tumour back then. So she had surgery, part of the pancreas was taken out, the spleen, and TACE. TACE is transarterial chemoembolization, so it's a liver-directed therapy where they inject a wire up into the liver and inject some chemotherapy down there to try and reduce the blood flow, and obviously there's some chemo in there. So she had that back in 2011. She was put on to sandostatin, but then had progressive disease, so now it went to the bones. She then went to St George and had lutate therapy, which again is a nuclear medicine procedure. What happens there is you're in the department for a couple of hours, 4 or 5 hours, 8 weeks apart. It's 4 cycles, and and you go home the same day. But it's a therapeutic approach that gives us whole body treatment. So she initially had a good response, but then unfortunately the liver came back, and then she had part of her liver removed, and then had some chemotherapy. So did I get all that right up to 2014?
I'm just trying to think what chemotherapy that actually was after my, probably more TACE. I'm not sure. Probably
an injection of something, but anyhow, just that's based on our records. You had some.
Oh, I did have some radio frequency
ablation. Oh, don't worry, I'll come to that. I'll come to that.
No, I don't know.
All right. So
I don't know. Ask Nick, he'll know.
No, that's all right. Somewhere in there, apparently, you had something that year. All right, so when we first saw Katie on our scanner, this is back in 2015, so this is what the scan looked like. So most of these spots are in bones. These are actually in bones, as is that, as are these. These are some spots in the abdomen. That's in bone, and this is all throughout the liver. All right, so you can see she's got a lot of bony disease, a lot of liver disease, and some lesions in the abdomen. We then gave her lutate, and were flabbergasted when we saw this soon afterwards. So what a response. So you can see all of this bone disease has gone. You know, it's quite amazing. The abdominal disease similarly gone, but there's still one spot in the liver. Most of those liver lesions went, but there was still one spot that wouldn't go away. We then did another scan, and unfortunately this liver lesion was getting bigger. So just the other thing, I put a yellow circle, that's actually the stomach. You're going to see that in a couple of scans, so don't worry about that. That's just one of the normal things. So again, just to orient you, that's the liver, the stomach, the kidneys. They're the adrenal glands as well, which are normal, and that's the bladder. So the only thing abnormal on this scan is the red arrow. She then had some radiotherapy. So this is targeted radiotherapy to that lesion in the liver. And so when we did our next scan, you can see so the red arrow had got significantly better. But you notice a few new things are starting to appear in the liver. The blue arrow and the purple, that's again the stomach, don't worry about that. So that one had responded, but then 2 new liver things had appeared. She then had SIRT, which is a selective internal radiotherapy, which is a nuclear medicine procedure, where again, they feed a wire up into the hepatic artery, into the liver, and we inject some yttrium-90 down there. And again, she had some TACE at the same time. So clearly the aim was to try and get the liver under control. So the next scan, again, you can see that the red lesion got a little bit better. The purple one completely gone, so had a great response, but the blue one was getting a little bit bigger. So then most recently immunotherapy and chemotherapy, and that's what Katie's scan looks like now. I think this was only a couple of weeks ago. I think I might have reported this scan, but so this is where she is now. Again, don't worry about that. The only abnormality is that lesion there, and maybe there's something there. But you compare where we were and where we are now, it's pretty impressive. And just to show you, again, we look at some various cuts through here. This is back in February of 2015, so early on in that journey, but you can see here on the CT, so this is a CAT scan. So that's the liver, that's the stomach, all of that. Bit of bowel out there, and obviously there's the bone. So you can see here that there are a couple of lesions lighting up in the gallium dotatate, completely gone. So they've totally gone after that lutate therapy. So really that's where we started, that's where we are now. So, you know, great response. In terms of FDG, again, we could be here for hours showing the FDG scans. The FDG scans show us the more aggressive disease. If it lights up on FDG, that's telling us this is a more aggressive disease that we've got to get in and treat. Back in 2016, when those liver lesions were appearing, you can see here that these lesions were all lighting up. So that obviously concerns us when we see that. And this is what her scan looks like today, perfectly normal. So the liver, nothing to see there at all. So, you know, I think it's a nice example of just showing how it's been a big trip, and I'm sure you'll talk more about it, but certainly, you know, for us, it's very nice to see that, you know, from having very extensive disease, things are very much under control. From what we can tell, there's no aggressive disease anywhere. There's still a little bit of disease in the liver, and we'll just be keeping an eye on that. So you will continue to use your platinum card. We will still see you in our department for the foreseeable future.
Thank you, Paul. The case was intended to demonstrate the complexity of the disease, but Paul simplified it a great deal. Each time point that there's a scan, there's a complex discussion, and in some cases, and we didn't present it all, surgery was involved, where we resected the area of cancer that we thought was growing in a disproportionate way to everything else. And Katie, of course, had to be involved in those discussions to agree with that. Also concerned about all the stuff that's been going on into her liver. We wanted to make sure her liver's healthy enough to tolerate things. So the department runs a scan that can measure the liver function and give us an estimate of what we call the reserve of the liver is to know what's safe to do and what not to do. So whilst we've simplified it all, behind the scenes, it's certainly far more complex than we're presenting with just a picture here. Not everyone, of course, goes through that road all the time as Katie has, but everyone may at some point certainly go through this aspect of the journey. One of the questions I had here was, can NETs be cured? And what is the survival rate, and what is the role of a GP in handling a NET case? So the question of a cure, NETs, like any cancer and tumour, can be cured if you pick it up early enough, isolate it in an organ and remove it. The trouble with a lot of NETs is that they can exist for a long time before they are declared, by which time they've already metastasized. So the question that then could be, and cure, and then the question is, how do you define cure? Cure means it doesn't come back, or it hasn't spread and it'll never come back, or you outlive the disease. In many cases with patients with NETs, our goal is to actually have people living with the disease. So that changes what we don't use the word cure, but we say that you're living with the disease and it's in remission. And outliving the disease, you could argue, is a cure in itself. But cure, in the medical sense, usually means it's gone for good. And we never can achieve that in many patients with neuroendocrine tumors. Alexander, do you have a comment?
On a number of occasions, and certainly in younger patients, we always send an appendix when we've done an appendicectomy for the pathologist to look at. And it's fair to say that probably in 1 to 2% of all appendicectomies, there is something, be it an adenoma or be it a neuroendocrine tumor in its earliest form. I think those are the patients that we actually cure. But the real issue then is, how do you make sure, and how do you make someone feel at ease? And certainly if you're a parent of a 16-year-old or an 18-year-old who has had a neuroendocrine tumor of limited disease, limited scope, where we all agree that the chance of that turning into something nasty is limited. But it's actually quite difficult to say, because it may be 10 years or 20 years down the road that something still might happen. And so that's a struggle for us to advise you the best we can, and certainly in terms of follow-up, because you don't want to have a 16-year-old that actually has a very, very minimal and slight chance of something happening go through follow-up year after year after year with investigations that probably do not mean that much in terms of predicting whether or not someone will have or will not have disease when they turn 26 or 30 or 35.
No, that's a good point. In fact, what's difficult for us is one of the questions here is around how often you do the scans, is establishing a framework where we have guidelines based on evidence as to how often we do things. So a bunch of us, through a group collaboration with Canada, went to a meeting 2 years ago to try to establish some international guidelines on follow-up for people who had a tumour cut out. And what we realized is that in fact there wasn't a lot of evidence to guide it. So it turned out to be what's called a consensus statement, everyone coming to some common agreement. And the meeting involved Canadians, Australians and Americans, and in the end, and some New Zealanders. Gallium scans weren't mentioned as a mandatory in that meeting. And you know why? Because the Americans don't have ready access to them. And they didn't want to promote a policy of using tests that they didn't have ready access to. If you had asked this panel what tests we'd prefer to have more often, for a low-grade neuroendocrine tumor, it would be a gallium scan ahead of a standard CT, although we do a CT with it. And so, to your point earlier, Alexander, one of the guidelines was who do you not have to do any tests to? And there is a subgroup of people who are lucky to have a very early tumor picked up by fluke or serendipity, and it's cut out, and if it has good features, you say, well, that person's chance of recurrence is so low, it's unnecessary to do their test. But when
you say so low, you actually say it's like a lifetime risk.
It's a lifetime risk.
1 or 2% of that's what we're talking about. So
yeah.
Really.
Because otherwise, as you said, the relapse could be late, up to 10 years. And in fact, very difficult to frame a policy of follow-up and how often you should check something that could come as late as 10 years.
Just want to say that it's very individual, because patients, like for you, when you say lifetime risk of 1%, it does mean something. But for most people, when you tell them that, they don't know what it means. What does that mean? Like, if I'm 1 out of 100 people, I have 1 chance of getting it, or I have 100 chance, but out of those 99%, I won't get it. Is that in 5 years? Is that in 2 years? Is that over the next 80 years I live? And some people are more prepared to accept no scanning, while others insist on having CT scans and gallium scans and other PET scans. And you explained that you seriously shouldn't go through this exposure to radiation certainty. There's no evidence that it will help detect the cancer at an early stage, and they still want to have it, while others are more relaxed. So that kind of like leaves us in a very difficult situation, especially that we do not have any clinical trial evidence to guide us what's the best practice. And hence, I go back to the main point that we need to do more research in this area to know what's best for our patients.
To talk about the level of evidence, there's A, B, C, and D, and E, and it's level A evidence that should drive what we do and what we advise our patients. And there's precious little level A evidence in neuroendocrine tumor. That is one of the main reasons why, rightly or wrongly, but it's understandable that if you go to different groups, different MDTs, even in different hospitals across Australia, but certainly if you compare it internationally, you'll get pretty different and variable advice on how to, certainly in follow-up, but certainly in primary management as well.
Well, I'd like to just echo what our other panelists have said and ask Kate and Meredith. It is a lot of patients who come to this diagnosis are already angry and suspicious about the myriad advice that they've been given. You know, once you've mentioned the cancer word, and then your doctor says, I've never heard of it, oh, let me look it up. Or so you don't have this trustful relationship. So it's very hard for when you do find good oncologists, well, I know you're a bit, oncologists who know the disease, it takes a while for you to build the trust. And I'd love to hear Kate's story, when you do have trust of someone, you can, instead of living scan by scan, you lose quality of life. And we're trying to capture what we know NET's patients' quality of life is difficult. It's impaired significantly. So you're going from that millimetre report of scan by scan, but once you do build that trust with an expert and a team of experts, I think you can let them do the worrying and trust that in Australia now, we are spearheading knowledge and treatments in NETs. And, you know, I think that's key to listen once you've found the right guy or woman. But what do you say, Katie?
I've got one here. Well, I think that the other thing that makes it very, very complicated, which maybe everyone will agree, is that despite I could hear all the moans and groans and that, ooh, you know, when you're looking at my scans, but throughout the process, I actually haven't had any of the symptoms that are associated often with neuroendocrine tumours. So I don't have the flushing, the diarrhea, the abdominal pain, but I've come across patients that have 1 or 2 tumours or no tumours show up, but they still are very symptomatic. So I think that that's what actually makes the disease very difficult to manage. And I do feel fortunate that I've got a team of doctors that instead of saying to me, well, you're fine, you're not showing that you're sick, you haven't got this, you haven't got that, so we're not going to scan you, they actually have to scan me fairly regularly to see what's going on, because the scans will actually guide their treatment rather than actually waiting for me to say, I feel terrible. And I think the only time I've really felt terrible was probably before diagnosis, because my blood sugar was dropping a lot. I didn't know what it was. I thought I was obviously having too many chocolate muffins in the morning and just addicted to them. But at the same time, probably only the last chemo I had, which was Folfox, was probably had the most lingering effects of me actually feeling dreadful and it affecting my day-to-day life. But otherwise, you know, I might be covered in tumours on my scans, but I actually feel really well, which I know most of us hate, because people will say, but you don't have cancer, you look so well. So it's a really hard thing, because there are patients that certainly don't have the tumour load I have, but they suffer chronically from so many of the symptoms that affect their day-to-day life. We often discuss toilet habits in our meetings, and it's quite common. But that is I know that that's a major inconvenience and a, you know, daily challenge for so many patients who perhaps don't have that sort of, all those black spots on their scans, but have other issues that they're living with.
Well, great point, Katie, because one of the questions is from Michaela Sherwood, who said, can a NET become more productive of hormones despite not increasing in size? So it brings up the topic of what's called a functional tumour. And we haven't actually discussed that so far, because focusing on yours, as you pointed out, you actually haven't had symptoms directly from the tumour, but you can have symptoms if it gets big enough and if the burden of disease gets big enough, or you can have symptoms even from a small tumour if it's producing lots of hormones. And the commonest symptom in that circumstance is often diarrhea, and other symptoms you can get hot flushes, and you can get symptoms related to hormones that produce high calcium. So there's a variety of things that can result from it. And
where the location is, if it's small bowel, that's small intestinal neuroendocrine that obstructs. If it obstructs, then sometimes that's the way patients are, if you like, found out, because there's resection and then you find neuroendocrine. But sometimes it's an on and off mechanism. So you're one of those patients that then has, for example, a diagnosis of irritable bowel syndrome, whereas in fact what happens is actually on and off you obstruct because of a neuroendocrine tumor that sits in the lumen of the small bowel.
Which is why we made, in one of our meetings, when someone tells us that they're having a history of cramping abdominal pain, look at a picture and recommend surgery, not because we think it's going to cure the problem, but it's going to prevent a complication. It's going to have significant impact on the patient, such as bowel obstruction. Or as in Katie's case, one of the tumours grows on the FDG PET scan, and we say this is behaving in an extremely different fashion to the rest of the tumours. We leave that alone. It's going to cause problems in the future, so you do a preemptive strike.